Good afternoon. My name is James O'Shaughnessy. I'm a non-executive director of HDR UK, and I'll be chairing this afternoon's session, which is entitled Relationship of Trust, Realising Patient and NHS Benefits in a Time of COVID-19. I'm delighted to introduce my co-chair and panel. Co-chairing today is Professor Sir Jonathan Montgomery, Professor of Healthcare Law at UCL and the Chair of Oxford University Hospital Trust. On the panel, we're joined by Angela Coulter, who is Chair of HDR UK's Public Advisory Board, of Phil Booth, who is the Coordinator of Med Confidential, and Jason McFall, the Chief Technology Officer at Privitar. The objectives of our session today are threefold and set out in the programme: reflecting on the lessons in building public trust for health data use for research and innovation during COVID, how to further build transparency through the commercial framework operated by HDR UK, and what opportunities exist for patient and NHS benefit through the next phases of the COVID-19 response. So just a little bit about the format. Each speaker, first Jonathan and then the three speakers, are going to give their 3-minute position statements and introduction into the topic. We should then have about 20 minutes for Q&A, and then at the end there'll be short chair reflections before we finish at 3:40 on the dot. So without further ado, I'm going to pass over to Jonathan, who is going to give an introduction into the topic. Jonathan.
Thank you very much, James, and good afternoon, everybody. I'm sure that we'll hear about these things in much more detail from members of the panel shortly, but I just want to begin by reflecting on dimensions around trust and trustworthiness, and also issues around what it means to be in an appropriate relationship over realising the benefits of data and other things for the NHS during these very unusual times of COVID-19. So start by thinking about what it means to make it worthwhile for people to place trust in the data initiatives that we're inviting them to participate in. There's a whole series of issues that we need to be able to promise to those potential participants in terms of the trustworthiness of our systems for security, our protections for privacy, and the things that mean that whether or not we think of them when we decide to place our trust, it's a reasonable thing for us to do. So our systems will need to be trustworthy, and we hope that as we discuss amongst the panel, we'll be able to explore dimensions of trustworthiness, how people can improve them, and what people might be looking for. So that's a first domain about a relationship of trust. The second domain relates to why we might, as individuals or organisations, think it's worth being part of this joint enterprise. What's in it for us? And it's important to recognise that we may not all want to participate in these initiatives for exactly the same reasons. And we've chosen our panel this afternoon partly because we guess that they won't all have the same concerns and the same reasons for participating. But if this is to be successful, then we all need to see enough benefit in this joint enterprise for it to be worth participating. So it might be that I'm interested in knowing that the NHS will be there for my family should they need it. Or maybe my career is as a researcher and I want to be able to build my reputation and make my contribution to the public good. Or perhaps I have a particular skill or technology that I can bring to bear to help us respond appropriately to COVID-19. And I want to make sure that the relationship of trust that we create makes it possible for me to do as much good as possible. The fundamental point here is that we don't all need to see the same gains coming from our participation, but we all need to think that being involved is worth it for us. If we don't enable that to happen, then we don't have a fair and mutual relationship, and we may be taken for granted as opposed to enter into a relationship of equal trust. So there are two domains I imagine we'll be exploring over the next half an hour or so. Why would we place our trust? What's in it for us? And what do we need to be assured of in order to make sure that we think we're involved in something that deserves the placing of trust? And with that, I'm going to invite Angela to take the stage next, or the mic next, I should say, for the first of the presentations.
Thank you very much. And can I have the first slide, please, or the next slide? Right, so the good news first. There is, I think, a silver lining to this pandemic, and it comes in the form of a greater discussion, public discussion about health research and indeed data and data science. We've seen an explosion of interest for obvious reasons in the media, among politicians and among the public. And who would have thought that, we'd be debating things like sort of technical terms like transmission models and R rates, et cetera, even in the tabloid press. So I hope that's led to at least some greater understanding than people perhaps came into this pandemic with. Secondly, we've seen a massive increase in willingness to participate in research. I mean, if you just look at the Zoe app, I think it's getting on for nearly 4 million people have voluntarily got involved in that citizen science project, which is fantastic. And then the recovery trial, which is, I believe, the largest of its kind in the world and is already producing really important results. And they seem to have had absolutely no difficulty in recruiting patients to join the trial. And thirdly, we've begun to have a more open debate about the really knotty issues, the kind of trade-offs that have to be made by things like access to our personal records and our rights to privacy. And particularly in the context of the Track and Trace app, I don't think that debate is finished by any means, but at least it's started, which is good news. Next slide, please. However, there are some signs that rather than building trust, this discussion that started has actually led to reductions in trust. This is data from a study that's still ongoing and not fully analysed yet, but run by the Reuters Institute at Oxford University. And they asked people where they look to for sort of trusted sources of information about COVID. And as you can see, this is covers a 5-week period. There have been reductions in trust in all these sources. So, for example, massive reduction in trust in government sources and politicians. But also, please note, a reduction, it's not nearly so big, but a reduction in trust in scientists, doctors, and experts. So none of us is immune from this. People are less willing to take what is said on trust. Next slide, please. And I think, again, it's much too early to try to unpick exactly why this is happening, or indeed if it is a real thing. But I should have mentioned that Cardiff University is also doing research into this area and is finding kind of similar things, I think, as yet. But we've seen an awful lot of examples of how not to communicate about health data research. We've seen lots of examples of very muddled communications and pretty dodgy statistics coming from all sorts of sources and repeated in the media, where, for example, graphs that aren't properly labeled and aren't properly explained and so on. And that I think people are getting frustrated with. Secondly, there's this lot of talk from government sources in particular about the fact that they're led by the science, but that can be quite confusing. It assumes that there's a single truth somewhere that they have access to, and there's single values-free science, when of course it's much more complicated than that. There are multiple sciences, multiple views, and very little is value-free. And alongside that, we haven't seen enough, I think, of acknowledgement of the kind of uncertainties and debates and knowledge gaps that are present in everything that scientists do. And thirdly, this really important issue of demonstrating trustworthiness. Again, I think the government has done badly here. There have been delays in publishing. They have finally published the SAGE minutes and they've finally published the SAGE membership, but the long delay spooked people. They wondered who was there, what they were doing there, and why we weren't being told. And when we did learn, I think we saw, at least, unless I'm missing something, I don't think we saw any patient and public involvement in SAGE, or indeed involvement from ordinary frontline health professionals, which seems to me a great pity. we've also seen, I think, and this is anecdotal, but I understand that notwithstanding some of the really great studies that are going on under the auspices of HDR UK, in general, studies coming through under the COVID umbrella have are less likely to have patients and public involved than is the norm of the studies that go through to the Health Research Authority. And thirdly, and in some ways most worryingly, there's been, partly because of, in the interest of speed, and I must say the sort of scale and pace with which these studies have been mounted is fantastically impressive, and anybody watching the presentations today has to agree with that. There have been some amazingly good work, and it's been put together incredibly quickly. But sometimes it's happened at the cost of cutting corners in things like privacy, consent, and scrutiny. There's been some discussion already today about the COPI, the fact that it's now possible to use data even from people who've opted out. I can understand why that's happened, but it's very disappointing, for example, that the confidentiality advisory group has not had a chance to have its usual oversight of what's going on. So I think we need to, I can understand why it's happened, but I do think we need to worry about this as it goes forward. The suspension is only until September, I understand, and we'll have to wait and see. But it's important that there is proper scrutiny of what's going on, even though all of us desperately need the research results, and very quickly. Thank you.
Angela, thank you for that presentation. I'm now going to pass over to Phil Booth from Med Confidential. Phil.
Thank you, James, and thank you, Angela. Just to pick up on what Angela's been saying, I think we may have some areas where we may come at things from different angles, but I think we've broadly agreed that whether we're in the pandemic or we're looking to beyond the pandemic, what Med Confidential has been advocating for, that every use of patients' data is consensual, safe, and transparent, are, if you like, the sort of three joined together pillars of what needs to happen in order for people to be able to make decisions and choices where they have them about what is done with their data, and how to, in the broader sense, engage people in the shared endeavour. Angela touched on the fact that the national data opt-out is being ignored by parts of the NHS, not all of them. Certainly NHS England X seems to be wanting to set it aside. NHS Digital will be taking it on a case-by-case basis for certain data sets. And there are other opt-outs, the summary care record, for example, and what's called the type 1, where people can choose to keep their GP record at their GP practice for their direct care purposes only. So when it comes to consent, it is understood. Under the COPI notices and other legislation, we are in an extraordinary situation. We are seeing research and systems being erected which could not be lawfully erected without those very particular emergency powers. We're going to have to think very carefully about, how, if at all, some of those systems are persisted. So I think it would be wise for us to build for the future rather than to simply think, well, hey, we're able to do it now, so let's think that we can continue to do that in the future. In that regard, the sort of central bit, the safe setting, something which I know HDR UK has been looking into very intensely, and there are examples of these safe settings now. NHS Digital has one, Genomic England Limited has one. The notion of a safe setting is not just security, it's making sure that the people who have access to the data are safe, the projects which they are doing are safe, the data itself is being handled in a safe fashion, it's only ever accessed in a safe setting where you've got all that security, and that you check and make sure that all the outputs are safe. Once you've got that sort of model and you have facilities to do it, and those are being used in the crisis, then I think we are moving towards, very rapidly, towards a much better situation than has pertained before, where population scale data sets were being basically copied in their hundreds to all sorts of third parties. But I think the main thing, and we're going to talk, I'm sure, about trust a lot, the main thing we need here is transparency. And as Angela pointed out, we just aren't getting the transparency that we need for trust. NHS England, said they would be transparent. We put in freedom of information requests for things like data protection impact assessments and contracts, ended up having to get to the point of suing them to get them to release that information. And we still don't have any sight of the proposed information governance scrutiny process for all those people who apply for these masses of data that they have under the COPI notices collected into their central data store. So we have previously proposed something called a data usage report that is in development, again, at NHS Digital. And this would allow that every patient could know what has been done with their data. Pretty much like your mobile phone account, a statement, or your bank statement, but about data. And what this would do is not just inform people and give them the information they need in order to make informed choices, but it would be a new communications channel, which I think is important both for the health service and the innovation that goes on within it, because we're going to see new services around genomic medicine, all that sort of stuff coming through, but also the research community to be able to feed back to people and show how, maybe this particular piece of research didn't necessarily affect you directly, but you have made a contribution to something that has a result that is good for all of us. So it's in combination, consensual, safe, and transparent, that I think we'll get to the place where the use of data is seen and able to be seen to be trustworthy, and then people can make that choice to trust.
Phil, thank you very much indeed for your presentation. And I know I'm just going to pass to Jason, who is our last speaker, before we move on to Q&A. Jason, over to you.
Thank you, James. So my position on this panel, I'm a technologist. So I'm Chief Technology Officer at Privitar. Just to explain what I do and what we do, we build software to enable large organizations like healthcare providers, banks, and telcos to do analysis of sensitive customer and patient data safely and responsibly, to manage and mitigate privacy risks. So we're about finding ways to enable safe use of data. And I think that technology is important here. Privacy is very, very complex, and it's really important to recognize there are no silver bullets, there are no easy answers. There's a lot of misinformation around things like anonymization. It's pretty much impossible to truly anonymize really rich data. But there are technical approaches that can really help with this problem. Limiting access to data, limiting the questions that can be asked of the data to only the things that have been agreed in advance, enabling data from different sources to be linked effectively, preventing that linkage, all these things. And technology is only part of the solution for sure, but it can be a very important part of the solution. We've all seen, I think, in these difficult times, just how technology can really help us to make progress at the moment in mundane things like video conferencing. My kids are learning through Google Classroom, using Slack all the time. And maybe this period will drive some changes in behavior for the better. I very much agree what Angela talked about there being a silver lining. So as well as things like maybe there'll be fewer business flights and more people using video to stay in touch with loved ones, maybe this will bring about a bit more critical thinking and a bit more focus and investment. So this period shouldn't all be about assuming that in this terrible time we're about hard compromises and avoiding the worst. I think we can really galvanize to do the right thing, even though it's a very urgent situation. I think everybody will recognize that technology brings huge benefits to society. It's the key driver of economic progress, and a crucial part of that is using data, and especially health data. But we have to be thoughtful about how we use our data. And this is where I think as a technologist, there's a real responsibility. We have to design the future that we want to live in and not sleepwalk into some future that we're not happy with. And that includes being very, very thoughtful about how our data is used. And so to echo what the other panelists have said, trust is absolutely critical to us all agreeing to pool our personal health data, for example, for self and responsible use. So let's not do anything careless or short-sighted that then we pay for very heavily later. Now, I mentioned privacy is subtle and it's not easy, but one of the great things about technology is it's very concrete. So you can understand it. You can inspect the source code. You can test it. You can take it apart and see how it works. You can make sure it's working as specified, and very importantly, you can check that it's sticking to the agreed design scope. And especially if you're open about this, publish the designs, invite expert scrutiny from a broad range of experts, maybe even make the code open source. This is, I think, a very strong way to bring rigor to the process, to change from talking about openness and transparency to really doing very, very concrete things to improve trust. And this is, I think, a key element of how technology can help this situation. As well as enabling data to be used, it can also enable trust because it's so concrete and inspectable. So I think there's great hope there.
Jason, thank you very much for that contribution. For excellent expositions by our panelists. Jonathan setting, I suppose, the domains for discussion really about how to make our systems trustworthy and to ask ourselves what is in it for us out of data usage and data sharing arrangements. And I think what we've heard here is really two stories, one of which is a silver lining of much more interest, much greater scrutiny of the kind of arrangements we're under, just much greater salience of the topic of health research and health data research in particular. But perhaps some policy decisions being made, possibly for understandable reasons, that are at risk of eroding the trust that we want to see in the system, and not always being carried out to the same standards of transparency that we might want to see. So I think a very useful starter for our Q&A, and I see some questions coming in. The first question that I'd like to pose to the panel is this. Has COVID changed the calculus of how we think about health data usage and sharing for research purposes? Do we think that the public feel differently now than they did 3 or 4 months ago? Has something changed? Do they feel differently about the trade-offs between privacy and liberty? And if there are any changes, are they likely to be durable? So I'm going to ask that question first to Angela, but give Phil and Jason a chance to respond as well before Jonathan takes the next question. Angela.
I think it's too early to tell. I don't think we know yet. We know quite a lot now about what the public thought before COVID, because there have been some very good research studies. For example, Understanding Patient Data has pulled together a lot of that research, and I think we have a much better understanding of that. But whether it's changed, I don't know. I mean, I think probably as the results are beginning to come out of the studies, people will see, and they maybe will increasingly see the value. But whether they become less concerned about, the issues we've talked about, privacy, consent, scrutiny, accountability, etc., I just think it's too early to tell. But I do think it should be a research priority from now on.
Thank you. I suppose the sort of concrete way to put it is, would you sacrifice something of your privacy in order to have the liberty to visit a family member, to go to the pub or whatever it is? Or is perhaps that the wrong way to frame the question? I'm setting this up for Phil to hand over to.
Yeah, I think that's a false dichotomy. I mean, yeah, you don't have to share data to have freedom. There are reasons why we might want to share data, but to cast that as something that is inherently necessary in order to have your freedom gets us into all sorts of problems, which we're going to have to tackle through the pandemic, like the argument around immunity certificates, for example, when, frankly, the evidence that's coming out of the research at the moment shows maybe 1 in 10 people won't even develop immunity. And we can have situations where people who are immune are still carrying the virus. Yeah, so I think we need to be really specific about the actual trade-offs that we are talking about here, and frame them within the actual evidence that we have as it emerges. I think in terms of attitudes, I mean, broadly speaking, I've been working in and around the sort of domain of privacy, human rights, identity, broader than health for now 15 years. And public attitudes are largely similar. They do change a bit over time, and they are very much affected by events. But those same concerns which I think people had going into COVID are, coming out in the sort of public sort of attitudes that I see at least, they're concerned about the involvement or engagement of commercial enterprise in and around health data. That's got very little to do with privacy per se, but how people perceive who is getting value from the data. So I think everyone's pretty much willing to give the government and certainly the NHS the benefit of the doubt in terms of having access to the data. It will ultimately turn out, I think, to rest on, okay, so what did you do with it? If we see a continued sort of scramble to try to put in place the sort of programs that we need to keep us safe through the pandemic and to last through to when we hope we get a vaccine, the trade-off's not about privacy. It's about competence and delivery for what we have actually allowed the government and NHS to do. And I think those, I think we, as Angela says, it's too early to actually tell exactly what this is. This is just, in my sense, I'm not sensing a big shift in people's attitudes towards, some of the companies that are involved and mentioned in the media, for example. And I don't see how that attitude is likely to change unless, there's a massive sort of improvement in the things that people can actually do. As you say, that's, if people can go around their life pretty much as normal, and that happens to have been delivered by something, involving one of these projects, that might make a change. But at the moment, it's very unclear.
Thank you. Jason, public attitudes towards data usage do vary according to the institution using the data. People seem to be very trusting of the NHS, but progressively less trusting the closer this gets to the private sector. How do you view it from the point of view as a company that's engaged in this endeavour, and with obviously a commitment to privacy baked into your brand?
So I think the first thing I would say, actually, just to mention your point about the trade-offs, is I think privacy is a public good. So I don't think individuals can say, all right, well, I'll give up my privacy, because my privacy impacts other people's privacy as well, who I spend time with, where I go. And so I think privacy is a public good, like healthcare or like freedom of speech. Among the people that we work with, they care very much about their customers. So it's organizations like banks, telcos, healthcare providers, where frankly, everything depends on trust. And I don't think we see that perhaps in some other areas, such as advertising, where there's a degree of exploitation. There's Shoshana Zuboff wrote this famous book, Surveillance Capitalism, about the extent to which, and I think this is pertinent here actually, we've allowed surveillance through commercial means to sort of creep in through, largely the internet giants. And somehow we now find ourselves in this position where there's this huge surveillance economy. And then we're saying, well, how did we get here? How did this happen? And I think partly there was a lack of respect for the consumer, and partly the consumer not being well enough informed and paying attention. But we mustn't allow that to happen in the healthcare arena, because if we have the same collapse of trust as we've had in some of the large advertising and internet giants, then I think we have a disaster on our hands.
Yes, thank you. I mean, I've, as somebody who hasn't previously had much exposure to the world of ad tech, for example, but having seen some demonstrations of what it can do, it's actually extraordinary what we have ceded in terms of our privacy in the private realm. And it's quite a thought to think how such a kind of technology might be used to prevent COVID transmission, but the extraordinary privacy, human rights, and other issues that might come about as a consequence, and how is there a way of utilising that kind of technology in a way that is at peace with the privacy and other rights that we have? So I think that's obviously a big topic for us to continue exploring. Jonathan, over to you.
Thanks very much, James. Thank you all for the questions coming in on the Q&A section of Zoom. I'm going to combine a couple of popular questions in, and I'm sure many of you will think I'm ducking one of them. So the most popular question looks like a Cummings question to me. It asks about the trust in people in leadership roles when they don't appear to follow the rules in the way that the public expects. But actually I want to turn that back on the panel and their areas of expertise, and combine it with the question about whether or not we have a greater need to explain the complexity of the data that we're dealing with. So our politicians, for I think understandable reasons, tend to want to oversimplify things, perhaps in the belief that that makes them more trustworthy for the public and easier for the public to understand. But it may well be that part of our roles from all of the sort of three groups of stakeholders that you represent has to be about encouraging a more mature discussion about the context and the complexities. And I wonder, Angela, if I could go to you first. My understanding of the data that we have around public and patient involvement is actually the public is pretty good at handling complexity, but I might be wrong, and this is your chance to disabuse me.
I don't think you're wrong at all. I think, I mean, clear communications is clearly key. And so are clear instructions. You know, how do we avoid getting this horrible disease? We need, and people constantly ask for sort of very clear kind of rules, if you like. But I think there's a difference between that and the kind of paternalistic assumption that we can't really cope with the idea that, you know, not everything is going swimmingly. You know, we aren't yet running a world-class track and trace system. We're in fact, we're certainly not world beating, we may be worst in the world. And, you know, if people are continually told that everything is hunky-dory and don't worry, just trust us, they react against that. And I think that may be partly behind this apparent diminution in trust. So, you know, it's time, I think, to treat all of us like grown-ups, to be very clear that there are different views on some of these issues, that there are difficult choices.
And Angela, if I ask about the practicalities of that, so if you're designing a research project, you want to take that seriously, you want to build your design, you want to share that complexity with groups of public and patients, what are the tools that we should be using to improve the quality of our research?
Well, we can do, and indeed there's quite a lot of good stuff done now, in using deliberative methods, for example, where people are presented with different views and they understand immediately when that happens. And I participated in some of these events that, you know, there is more than one view, that experts disagree, that, you know, that there is a public debate out there. And the evidence from those deliberative approaches is that when that's upfront, most people are very capable of coming to very good decisions, even to build consensus among themselves, even after disagreeing with each other, that people can see it. It's I think it sounds terribly simplistic, but it's about treating people like grown-ups, I think. Thanks,
Angela. Phil, I wonder if I could turn to you and the balance of your experience in terms of the transparency and exposing our vulnerability. I think you used the phrase competence. Quite a lot of the transparency that we see is transparency over data breaches, the failure of things to work in the way that they were promised to work. Are we grown up enough to be able to realize that the world is imperfect? And perhaps are we expecting too much, particularly in the time of COVID, for what can be done at the pace we're trying to do it?
I don't think so. You know, what we have in place are information governance and transparency processes, scrutiny processes, which are there and available. Angela has mentioned CAG, for example, NHS Digital, there is iGuard, and, you know, there are other processes which have already been in place. That, you know, other bodies, NHS bodies or whatever, you know, are erecting vast new information systems does not mean that those need to be detached from the already established processes, which are being ramped up similarly. Yeah, these bodies are sitting far more regularly, publishing their deliberations much more regularly, and, you know, we need to stick with it. And it goes to your point about, you know, the whole Cummings thing. Process, yeah, is a defence against rogue actors. Yeah, I think the public will see the system, that, you know, things are fair when it is seen that the same rules are applied to all. You might not be able to stop an individual driving up to Durham or what have you, but when it comes to, you know, access to the whole nation's or whole population's medical records, there has to be a record of how this due consideration, this process, these approvals, all of those things, which are there and being done, you know, are surfaced for everything. And I think we obviously in that are going to occasionally come across instances where things have been less than satisfactory. But I think we are grown up in terms of being able to make our own choices about that. If someone says, look, we screwed up, yeah, and this is how we have changed things to make sure that that doesn't happen in future, that is actually more trustworthy than simply saying, trust us, yeah, we're not going to show you what's going on in the workings. Yeah, so I think we do have that. Trust goes both ways here, I suppose. Is the thing I'm
so that implies actually this is the time to hold on to the fundamentals of good governance and trust, absolutely, not to abandon them because we're under pressure.
Yeah, and that's also in the laws. I mean, the COPI notices Regulation 3 is what provides the lawful basis for the extraction and processing and dissemination of the data, but Regulation 7 still requires that you meet all the other requirements of the relevant laws. So we can't be throwing the baby out with the bathwater, and especially if we want to come out of this with a stronger, more robust system.
So we might get into an acronym quiz, Control of Patient Information Regulations, and I'm sure everybody on this call knows exactly which is in which regulation. But I wonder whether, Jason, you were hinting at a slightly different approach that might be coming to the fore, which was probably as well as instead of those fundamental governance structures, a sort of privacy by design, the opportunities that technology bring mean that we don't so much have to take it on trust, that actually we might be able to make it much more difficult for people to act in an untrustworthy way if we exploit the opportunities of technology. Did I understand you right in thinking that?
Yes, that's right. I think one of the very important things is to agree what we want to use our data for, and then make sure that it's used for that, and very importantly, used effectively for that. So we don't want to put barriers in the way that mean that then it's too hard to use data, or maybe that it's not possible to extract all of the detail or value from that data, and worst of all, draw false conclusions. So you want to make data useful, but only for the purpose that was agreed. So, and there are smart ways to do that. So it goes beyond just what I think of as security, so restricting who can access data, but limiting the inferences that can be drawn from data, limiting the questions that can be asked of the data to those questions that were agreed up front. And there are smart things that can be done there. It sort of relates to, for example, the debate going on around a centralized or decentralized track and trace model. These have trade-offs and pros and cons. Let's talk about them. Let's lay out what those pros and cons are and why one might want to use one choice or another choice. I think, going back to the original point, the public can engage in these topics and decide how they feel. But these things just aren't being exposed and aren't being discussed. And technology isn't going to solve everything. You need process, you need honesty, you need good communication, but it certainly can help. And then you can allow that inspection of what the technology is doing to make sure that people aren't going around the sides or doing something that isn't what they promised.
Thanks very much, Jason. I should perhaps declare an interest as chair of the Ethics Advisory Board to NHSX on the contact tracing app. And interestingly, one of the things that we've debated is the public might be too trusting. The evidence is a lot of people have downloaded the app. A lot of people put their trust in the NHS brand. But the centralisation, decentralisation debate is interesting because on the technology side, people say we don't need to trust as if it's decentralised. And yet there's a lot of uncertainty about the advice that we're giving, and whether it's safe to decentralise and not know, is perhaps the big question which we don't have a chance to resolve now. And I'll hand back to James.
Thank you, Jonathan. Well, as the token politician on the panel, what I would say is that I think politicians worry about seeming not to know the answers to things, which is, of course, a sort of epistemologically problematic mindset, because no one knows the answers to everything. And so there is probably a tendency to try and not get into complexity and actually to try and deliver simple messages. Simple messages in the right context, I think, can be the right thing to do, but sometimes problems are just difficult. And I think everybody recognises that the response to this crisis has been a public policy challenge like no other. And I would tend towards honesty about the difficulty of some of these issues and trade-offs, rather than trying to oversimplify where simplification isn't possible. But there you go. I can say that, and I'm not in government at the moment, so easy for me to say. But in terms of just following that up, I mean, the one of the questions that I think has probably been answered as well, related question, which was from Derek Stewart on the list, about longer-term risk when people find out their data is being used without being communicated to them. I think it's probably, we've covered that, I think, but I think it's fair to say that difficult conversations are best had at the beginning, rather than afterwards. And actually, some of the examples I've seen on that, I attended the One London deliberation about health data usage a few months ago. And that was just an extraordinary deliberative process. We started, having talked to a number of the participants, from a position of skepticism, but people by the end were saying data must be used appropriately, safely, legally, and so on, where there are health and other economic benefits to be generated. And so people can go on that journey, not to be persuaded or brainwashed, but to understand what's possible, and then to go about it in the right possible way with maximum transparency. So I think that is the right kind of approach. Looking at it from a different perspective, Chris Carrigan has asked a question about not looking at it so much from the patient perspective or citizen perspective, but from a researcher perspective, where he'd said a number of the long-standing barriers to data access have been removed because of COVID. There is much more liquidity of that data. But how many of those barriers ought to stay down post-COVID? And who makes the decision about that, and on what basis? I think that's a really good question to think of it from that perspective. So I'm going to ask Jason, first of all, if he might give a perspective on that.
So I think one of the dangers is that once data is out there, it's hard to get it back in many cases. Once data is been published somewhere or shared, and it's then copied and copied further, you can't put the genie back into the bottle. So it's great, I think, to have availability of data, but we have to make sure that we think about future controls as well as usage today, and have mechanisms to do that. And that might be as simple as commitments to delete data when it's no longer used, but also I think a degree of control over who data is being shared with. So I think in the urgency of the moment, I've certainly been involved in conversations where people are being asked for data and thinking that it's the right thing to do to share it, and not thinking about the broader implications. And once it's out there, it's out there. So we have to think about it early.
Thank you. Angela.
Yeah, I am thinking about personal data, my electronic record, for example. I wish a number of things, but one thing I wish is that I was seen as the custodian of my own data rather than some other body, and that there was, or there could be, and indeed in some cases there already is, a system of dynamic consent, which would mean that I would be able to see every time somebody wanted to use my data, and I personally would be delighted if they use it, because I think there's an awful lot of data sitting around that isn't used, but not everybody feels like that. But if there was some way in which most people have never seen their own electronic record, they've never seen their health data or even a paper record. And so so it can feel very strange to be asked to consent for something at the beginning of a long study, which might carry on for 20 years or so, if it's that kind of study, and never to know what's happened with your own data. So I think what I hope will happen is there'll be a change of view in who controls the data. I loathe the term data controllers, but if we were seen as our own data custodians, and we were able to donate our data, rather like we donate our blood, I think the whole public discussion would change.
I want to believe you, in the sense that I want to believe there is a world in which people are intensely interested in their health data and how it's used and what benefit it might be put towards for their own benefit and wider society. But are people actually that interested? I mean, we happily give away all our information to Google and Facebook and others, and most people would have no idea about how that is used, often against their benefit. So is it realistic?
I think you're right. A lot of people aren't interested, but there is also quite a lot of altruism, and that's why people get involved in studies, because they want to help not only themselves but people like themselves. Most people, it's usually explained to people when they join a study that, you know, it's not going to benefit them personally, and yet they still go ahead. So there is, and you know, we can build on this fantastic commitment to the NHS and belief in the NHS as a force for public good. So some people will not be bothered, not interested, but hopefully still allow their data to be used.
Right.
And that, I think, is the case already. And some people will really want to know what it's being used for, and you know, will want to give their permission to particular requests for its use. So I'm not so pessimistic.
Thank you. Phil?
Yeah, I wanted to sort of push back a little bit on the premise of the question, actually. I hope that barriers have not actually been removed. As we said with the control of patient information regulations, data can be extracted and as being used by the relevant national bodies, but they are telling us that they have got proper contractual controls about those third-party processors that they are sharing the data with. They are saying, and the NIHR, the National Institute for Health Research, and the Health Research Authority are publishing the lists of approved studies. So unless someone can tell me otherwise, you know, which of these barriers have actually been removed? You know, we are having to speed things up, absolutely, and that may mean that some of the scrutiny is, you know, a little less than it previously might have been. But by and large, I'm not aware of, you know, any national body that has gone completely off the reservation at this point and, you know, basically broken all the rules. You know, we aren't seeing all of the information governance and assessment and scrutiny processes surfaced yet, and that's a problem. But yeah, I think we have to, you know, the element of trust here is that we're being told it is going on. We want to see the evidence. On the other point, I mean, this is why we use the word consensual. Yeah, the situation that Angela described essentially is of dynamic consent, is someone having to consent for every use of their data, which is fine, as you say, for those who are interested, but would not be the case for people who just don't care, or, you know, who just decide, forget it. Yeah, which is why we say, you know, we probably need a mixed economy of consent, in the sense of, you know, you can make certain decisions which affect, you know, certain uses of your data, as we currently have, the opt-outs or dissent mechanisms, and then there is consent. You know, most of the big studies, like the one that was mentioned, Zoe, for example, these are people consenting to do something. 4 million people chose to volunteer some data about themselves and whatever else it is that Zoe and the universities, with their Health Research Authority, Research Ethics Committee approvals, have chosen to do. I would suggest that, you know, the one area of difficulty around Zoe is the fact that the MOD is sucking up a copy of the data, yeah, through JHub and Project Oasis out of NHSX. You know, when those sorts of things come to light afterwards and they haven't been properly communicated to 4 million people who have consented to what they thought was basically a research study, that's where we get into trouble. Yeah. So this is why I think consent, you know, safety and transparency all have to go together, because if you let, you know, one slip, then you've got, you know, you've got a problem.
Right. Thank you very much. Well, look, we've now run out of time, so I'm just going to pass over to Jonathan to give a quick chair's reflection. I think it's been an incredibly rich discussion, lots of topics covered, and some consistent themes which Jonathan will now expand on. Jonathan.
Thank you for that daunting task in 90 seconds or so left. I guess I'm not surprised we haven't solved all these problems in 50 minutes. And I'm going to go back to something Jason said earlier on, because he got let off the hook on that last question. He's not going to have to comment on this, but you made a comment, Jason, about privacy being in some senses a public good, because infringements in one person's privacy also diminish the privacy of other people, our interconnectedness. And I wonder whether we need to think a bit more about that dimension in relation to data. So in many ways, the data only exists because we collaborate. The Zoe data only exists because a whole load of us choose to input into it. Our health data only exists through interactions where we go and see the clinicians who support us. We have tests done. We can't get it in the abstract. we may want to make sure that we get a set of common understandings about what makes that useful. But none of that, of course, takes away some basic constraints about respect for our rights to privacy and protection. So I think we've been exploring how we build a relationship of trust which is likely to be a common good where we share. And at the same time, we're looking at some parameters of that that are not, we can't trade off, which are about our individual rights. So I guess that takes us a bit back to where we started. Thank you very much to Angela, Phil and Jason for what I think has been a very rich discussion, and I apologise to the audience frustration in that we've only been able to scratch the surface of some really interesting questions. But I hope you found it illuminating and interesting, and I hope it's left you with more questions than you had to start with, because that's the whole point of panel sessions. Thank you very much.